to estimate the probability of having obstructive coronary disease. Now, importantly, if you have seen these tables have now been available for over 20 to 30 years based on the Diamond and Forster criteria. They got modified in the Duke clinical score, but the European guidelines actually, even though this table might look familiar, the estimates are completely new. They revised them based on contemporary data of patients that are referred for testing today. And I would share with people that the older tables, for example, the Duke clinical score or the Diamond and Forster, were actually based on invasive angiography and even pathology and autopsy data. But in the current era, this is a very important point, when this table was revised, and this was just a year ago, the estimates that they provide here are 1/3 of that predicted by the model used in the previous version of the same guideline, okay? 1/3. So that means our patient that I showed you before, who was in his 40s, even if he had typical chest pain, his pretest probability would only be 22%, which is actually low. In fact, even if you take a 60-year-old male with typical angina, the pretest probability of obstructive disease, only 44%, so that would be low as well. In fact, all these estimates in this entire table are less than 50%, with the exception of men who have typical angina and who are over 70, and even then this is only 52%, which would be classified as intermediate risk. So I think one thing we can all ask is, who are the high-risk patients today? Because this table certainly doesn't help us identify those. So I talked about stable chest pain. I also want to mention that we are now having some data from 2 trials using CT in low-risk acute coronary syndrome patients. And part of this is because our high-sensitivity troponins now are so sensitive that they can detect injury. So this is actually a case from my hospital from about 3 months ago. A 38-year-old male who came in was really atypical chest pain, had a negative EKG, very mild elevation in troponin, and the team was pretty insistent that this is myocarditis. This guy was also a marijuana user. But before going home, they just wanted to make sure his EKG was normal. Let's just make sure the coronaries are okay. This was a CTA that they did pretty much as he was about to leave the hospital. And to everybody's surprise, he had a complete thrombotic occlusion of the proximal RCA here. And importantly, there's also evidence of plaque, not just in the RCA, but also in the LAD. You can see a small amount of plaque here, suggesting that even though he was only 38, he already had evidence of diffuse coronary disease. So this is an example of CTA in this population. Now, I talked about plaque and I talked about stenosis, but CTA can show us much more than that. It can look at some plaque characteristics that have been associated with high risk. There's a technique known as CT-FFR that can estimate blood flow based on some modeling and other techniques that I will not get into right now. And while CTA is very useful in patients that don't have known coronary disease, if we can get good image quality, it's important to know that certainly there's many cases where coronary CTA is not going to be a good test. Patients who are morbidly obese, such as this patient here, we're going to have very noisy pictures. Patients that have a massive amount of coronary calcifications are going to have CTAs that will be indeterminate, that we won't be able to see because the calcium obscures the lumen. Patients that have stents, especially if they're small stents or multiple stents, are also not going to be evaluable by CT. So on this slide, I'm just showing some advantages of coronary CTA versus functional testing. CTA, I think for a long time, we know is very good at ruling out disease. In fact, not just stenosis, but plaque, and it can detect subclinical plaque. Functional testing, on the other hand, can really tell us if there's ischemia. And we know that despite the ischemia trial, when patients have significant symptoms, we may also want to think about revascularization. I would say driven more so by symptoms now than anything else. I want to show you also how we use testing such as nuclear stress testing in patients that have known coronary disease. And this is our next case. This is a 68-year-old male. He has diabetes and hypertension, prior PCI to the LAD. He now had a recent non-STEMI worsening heart failure, and because of the heart failure, he is referred for more testing to see what is the magnitude of ischemia. And for the sake of time, I won't go through our panel here, but if I show this to everyone, you can see that there is a perfusion defect in the inferior wall, including the apical, mid, and basal segments, that is mostly reversible. So this inferior wall here, we can look at the rest images, and you can see that the tracer fills in. We can see this on the very bottom set of images as well, that the inferior wall has a defect that's reversible. Importantly, in the LAD, if I ask you, no perfusion defects there and nothing in the circumflex and no ischemia. And in fact, when we look at the invasive angiogram on this patient, we see severe stenosis in the right coronary artery, which certainly corresponds to the ischemia that we are seeing on stress testing. However, let's look at the other coronary arteries. And on this slide here, you can see 3 images showing the LAD. And if you focus on the top right image, you can see that the LAD is a small, it's a large vessel. It goes all the way to the apex, but the caliber is small, and it just has a lot of diffuse disease. And if I asked any of you, is there any severe stenosis, you would look really hard at this, but I don't think anyone can really see a single severe lesion, but you would describe this as severe diffuse disease. And this is something that we see commonly in patients that have diabetes. And the question is this flow limiting? Well, you can say that the pictures I showed you did not show any ischemia in the LAD, but I would tell you that particularly in nuclear images where we look at relative differences of blood flow, if there is a severe defect, and in this case there was one in the right coronary artery, that may reduce our accuracy to detect ischemia in other distributions. One of the ways we can answer this with PET is by measuring blood flow, and this is a technique where we can quantify blood flow at both stress and rest, and quantify a number known as the coronary flow reserve. And in fact, in the particular patient here, when we quantified this, the peak myocardial blood flow in the LAD was about 1.0. Normal should be more than 1.8. So when we do our quantification, we see severe abnormalities in flow here, not just in the right coronary artery where we saw visual evidence of ischemia, but we also see severe reduction in flow as well as in myocardial blood flow reserve in the LAD. Based on this, when this study was reported, and on this slide I'm actually showing you the report that we put together, we wrote that there are no perfusion defects in the LAD or the left circumflex, but the flow reserve is reduced, suggesting flow limitation. And based on these results, this patient underwent CABG, including a vein graft to the RCA, and remember I showed you severe ischemia on the RCA, but also a lima to the LAD. And this is important because we know that patients with diabetes and LV dysfunction have a benefit from revascularization with CABG. We've seen this in the FREEDOM study. And part of the benefit there, of course, is that we bypass a large segment of the coronary artery. So essentially, we are protecting any events that can happen in that LAD by bypassing it. But part of it also has to do with the fact that there's very diffuse disease in that LAD that leads to ischemia as well, even though this is a technique where we can quantify this and overcome some of the visual problems. So on this slide here, I'm showing some of the compelling indications we have for functional testing. Functional testing, whether it's PET or stress echo or stress MRI, is really best for patients that have known coronary disease, a prior revascularization. It's particularly helpful if we want to identify the benefit of revascularization, to know if somebody's symptoms are due to ischemia and to see how much ischemia there is. Despite the ischemia trial, we know that patients with more ischemia generally have worse outcomes. What we do know now that ischemia alone should not be used to decide on who to revascularize. We really have to think about symptoms as well, and of course patient preferences. That PET can quantify blood flow, and this has many implications that I'm not showing you today, including evaluating patients that have diffuse non-obstructive coronary disease, that can have microvascular disease, or sometimes we use the word INOCA, which is ischemia with no obstructive coronary disease. We can evaluate with PET patients as multi-vessel disease, where the quantification can help you and overcome some of the challenges. And in general, PET is a more accurate test than SPECT that also has lower radiation. And I would tell you that I personally am involved with doing stress MRIs and nuclear stress test and echo, and I personally feel that PET probably one of the most accurate techniques we have in terms of measuring how much ischemia patients have. So here are some take-home points here. When you want to evaluate someone with chest pain, and this is my last slide here, one is we always have to consider the local availability and expertise. Obviously, MRI and PET are not going to be available in many centers. Exercise treadmill test is still a very helpful test to see who has angina and what is their exercise capacity. Patients that have a high exercise capacity, I personally feel very comfortable treating them with medical therapy, even when they have severe abnormalities and ischemia. Coronary CTA has now been observed to be associated with a lower risk of myocardial infarctions, and the likely mechanism for this is that we can detect more plaque and implement more preventive therapies. Functional testing, we talked about the fact that it can help us assess the benefit of revascularization, especially in patients with low ejection fraction or patients that have frequent symptoms. And finally, I think as we now made the point multiple times, patients with stable chest pains can be treated conservatively if their symptoms are tolerable. But I would remind everyone that in the ischemia trial, those patients all underwent CT to exclude left main disease. So I think when you are trying to decide whether to treat someone conservatively or not, at least in some patients, doing a coronary CTA to make sure they don't have really high-risk anatomy might be reasonable to do. So I'll stop it right there. I know we covered a lot of information.
Thank you, Ron. We are a little over time, but this is such an important topic, so let's discuss in a little more detail. While everybody is thinking up questions, there's a fantastic question from the audience, which is a very clinically focused one. Why did your patient, the first one in this presentation, have chest pain at a time when the CT had resolved his stenosis?
I presume this refers to 4 years later. Why did he have chest pain? And certainly in the absence of ischemia and the absence of significant coronary disease too, I would say the most likely thing would be, in this case, that it was non-cardiac chest pain. I mean, we can certainly talk about microvascular disease and other entities that lead to chest pain, but ultimately in this guy, he had symptoms that were concerning enough to do testing, but I think having the information from the imaging, I would say his pain was likely non-cardiac. And it's since gone away, and he's doing great.
So the CT acted as the therapeutic treatment for him.
Well, reassurance is really reassurance is something that a lot of stress testing does provide. So.
Tell him to stop talking about heart disease with his friends.
Yeah,
exactly.
Go ahead, Nat.
You know, nowadays, if you want to be just a solid, good clinician, it's hard. I remember a patient coming in, referred to me by a primary care doctor. I'm seeing the after discussing, taking a good detailed history, I told him, you know, there's no need to. I asked the fellow, what do you want to do? He said, stress test. I said, why? Do you think he has coronary disease? His symptoms are really angina? He says, no. Then why do you want to do anything? And he said, well, the doctor sent him here, the primary care doctor. I said, he didn't send for a test. He wanted our opinion. And so there are patients, I would tell them, I'll spend time explaining, talking to them, tell them, you know, there is really nothing to do with the heart. You don't need any tests. Sometimes tests give you iffy answers. That will lead to another test. And so how often clinicians do that now?
Right. So
well, along those same lines too is I think the data that Ron showed about the risk of high risk of events in people with normal stress tests. And why is that? Obviously, plaque rupture is probably a great explanation. And I think that the tendency is for patients in particular to have a normal stress test and think that everything is normal and everything is fine. And as Ron pointed out, it's not fine. We're missing non-obstructive disease or the potential for non-obstructive disease. And if that is not adequately treated, then you open up the patient for future events. So paying attention to risk factors and aggressive risk factor modification despite a normal stress test, and convincing patients that a normal stress test does not equal no disease. And taking the time to explain that, I think, is really critical.
Yeah, I think Vera, that puts you in a little bit of a bind here, right? What if the ACC chest pain pathways comes out and says stress echo cannot predict future events, and the ischemia trial says ischemia is not that important? So does the CT crowd win then, and stress echo has to?
Well, I think Vera's point is really, really important, and I think ultimately prevention, our ability to implement prevention should not just hinge on the stress test. So, you know, we talked yesterday about calcium scoring, and I think if you add calcium score to any test, a stress MRI, a stress echo, you kind of win, because now you know who has plaque and you implement preventive therapies. Or maybe you don't need the calcium score and you can look at risk factors and do other things. But if you treat patients aggressively with preventive therapies, that's by far the most important thing you can do, even if they come to you for symptoms that have nothing to do with their heart. And the reason why most events occur, in patients with non-obstructive disease is also the denominator is much bigger for that group. There's just so many more of those patients. It's not that those plaques are all high risk, but just the denominator is so large, most patients have non-obstructive plaques. So that's really kind of the point there.
Yeah, and I think that we can't do a test on every single patient. So I think Matt's point of being a good doctor and really spending the time talking to patients about what do these tests show us, what are the benefits, what are the limitations, what are the specific characteristics of you as a specific patient, and what can we do to help you live longer despite the results of a test. I mean, I think the advantage of a test, as Ron pointed out yesterday, is that you could actually see the plaque, you could actually see the arteries, which may be a very powerful motivator for patients. Cool. But do we have the resources to test every single patient? No. So really sitting down with them and being aggressive with the information that you have to convince them that they need to do a better job of caring for themselves.
So last question from the audience. This just leads into the discussion we are having. In the Scott heart, there's been controversy why there was benefit, right? And so the question is the 5-year Scott heart data. Was CT resulting in sufficiently greater statin use which made the difference, or was it something else?
Yeah, and it's a good question. What is the mechanism for the benefit? And obviously the trial was not designed to give you that answer, but there's been some good studies, including one published a couple months ago in JACC that tried to look at that. And a lot of it is thought to be due, especially in kind of lower risk individuals, to more preventive therapies. Now, if you look at the absolute difference in medical therapies from the CT arm compared to the functional arm, the delta is not as impressive as we would think. But the important thing is in CT, it's not just that you're giving more preventive therapies, but it's actually getting to the right patients. So it's the patients that have plaque. And when you look at who gets on a functional study, you look at who actually gets preventive therapies, it may not correlate with patients that have no coronary disease, which is at least half the population in some of these studies. So it's not just you're giving more therapies, but you're giving the therapies to the patients who are more at risk, which is thought to be one of the things. And obviously it's not just therapies. The trial did not look at this, but lifestyle interventions, control of blood pressure, more aspirin use. So there's plenty of other things driving it. The revascularization has always been a hot question. There was a signal of early revascularizations in Scott heart in the CTA arm. When they looked at 5 years, there was no more a difference. So some patients in the CT arm were getting more invasive angiography and revascularization early on, and those who are not in the CT group kind of caught up by 5 years. So that seems not to be driving most of the benefit here.
Chandra, can I raise a point?
Yeah, please.
We have go through different phases of. There was a period coronary spasm was dominating. Okay. In fact, when I was staffing the cath lab, if the coronaries are normal, I can't send the patient out without ergonovane testing. There was a period, every spasm. Now nobody talks about spasm. Okay, once the
Except in
angioplasty
Japan.
came,
Except in Japan, they still do a lot of
yeah,
testing.
yeah.
Korea and Japan.
But I would remind people
I
that
think
spasm
that
occurs on top of plaque. Spasm
right.
doesn't happen in a completely normal vessel.
Yeah, that's what it's a minimally occlusive plaque obstruction can be turned into a significant obstruction in the setting of a spasm.
Correct.
What I'm saying is, it's not always mechanical aspects. We have to think of the coronary functional aspects of the coronary artery behavior, and there needs to be more thinking about the role of spasm in any given patient.
So Nat, your Melvin Marcus training is showing up, who talked about coronary physiology at the University of Iowa. So it's getting to be a very complicated time, right? So Ron, we probably wouldn't have time to discuss all this. But the ischemia trial, one of the side studies that's coming out is the functional testing, the degree of ischemia did not predict events, mild, moderate to severe, compared to anatomical difference, mild, moderate to severe. This is going to be a tectonic shift because all our testing is right now based on detecting ischemia, and the foundation for treating ischemia to treat events always has been shaky. It's based on one big Rory Hakamich paper to start with. But if that is true, that increasing severity of ischemia is not predictive once you have good medical therapy, while increasing anatomical obstruction is predictive, next year if we have this discussion, we may have a different answer.
So I would say that is true for patients who got enrolled in ischemia. There was no difference in terms of the gradient of ischemia and outcomes. But you have to remember the folks who are enrolled. And I know I was recruiting patients at Brigham for this. And when you have someone with a really abnormal nuclear study and TID and they're dropping their blood pressure, or they have a low EF, you never randomize those patients. So you always have to keep in mind who are the patients who are in the trial.
Here is a fun fact. Did you know one of the largest enrollments in the ischemia trial was from India? They contributed a lot of good patient material into the trial. Okay, I think we are 15 minutes behind, so we should probably move on to a topic which you want to unshare? Yeah. So a topic which somebody, it's like politics. Either you hate it or you love it. So let me see the topic of viability. Okay, again, this will be an interactive case-based session, so our colleagues should participate freely. Can you see the slides and see the audio?
Yes.
Okay, yeah. Good. Okay, let's start with the case. 69-year-old man comes with increasing shortness of breath, but no significant chest pain. The change has been gradual for 8 months and is now associated with TND orthopnea in the last few days, has diabetes, controlled hypertension, history of smoking, all the heart failure signs, JBP is up, sharp VY collapse, edema, third heart sound. So here are the echo images. What would you guys think is the abnormality, and what is the chance it is ischemic, and what's the chance that we should revascularize? Go ahead, anybody.
Well, there are more than one area of contractile abnormalities. So probably multi-vessel coronary disease in all likelihood, at least 2 vessels with severe LV dysfunction, coupled with functional mitral regurgitation. Not surprising that patient has the symptoms of heart failure. Looking at a septum that almost looks scarred, I doubt it's viable. And but as probably so is the inferior wall. I would do a low-dose dobutamine, some form of viability study.
Okay, so you would do that.
My concern adding to that is that the ventricle is dilated, and the more kind of adverse remodeling and dilatation, even if you see viability, the likelihood of functional recovery goes down.
Agreed.
Okay. How about you, Vera?
I agree with all the comments that are made, and I agree with the distribution of the long motion abnormalities and the ischemic MR. In terms of what study to do next, obviously this is a viability session, so viability is going to come in here at some point along the way. But I would make the argument that perhaps we want to do an angiogram first to look for any critical disease that may make a viability study a little bit dangerous, depending on what form of viability study that you want. And just so you have an idea of the anatomy to put into the context of your viability study.
Okay, so three things come out of this. All of you think a viability may be an option, but Nat thought there is so much scarring and thinning of a wall, so it may not improve. Ron thought the dilated ventricle doesn't portend a good prognosis. And Vera thought we should first find anatomy before we test for viability. Fair enough.
I give you the anatomy. Circumflex and right coronary and LAD are gone.
Okay. Two of the three. Okay. So here is what we have. We had found on the angiogram 2-vessel disease, proximal LAD and RCA, severe LV dysfunction, thin akinetic walls with scarring. And so the question is, will our patient benefit with revascularization? Among the panel, how many of you think with all the data that you have read and know about, is there still a role for viability? Yes or no? Nat?
You know what? I don't know the anatomy. Is it totally occluded or?
No, not in this. So you think viability has a role in patient care?
In this
yes
case,
or no? No
in this
hedging.
case, it may not.
Make it easy. Yes.
Yes. Vera?
In selected cases.
Okay. Okay, let's see. So what do the guidelines recommend? If you had just gone with the guidelines, this guy is 2-vessel disease with proximal LAD, right? So we would say he needs to go for CABG. If he didn't have proximal LAD, he would not need CABG irrespective of everything else. Now these guidelines are the coronary revascularization guidelines, but these are the guidelines which look based on symptoms, right? This guy has no ischemic symptoms. So if he has no ischemic symptoms, if you are asymptomatic here, as you see up in the big circle, and if you don't have diabetes, there's really no big prescription according to the appropriate use criteria to go and do something, right? If you had diabetes, it gives you one little escape door, a 7, in patients who have high-risk findings on non-invasive testing, right? So at this stage, the two guidelines are not very clear what to do. One says go ahead and operate, the other thinks you may have to operate if there are high-risk findings. So how do you find this out? So, and this is the general structure I use, and Vera is exactly right. Before we embark on this journey, we have to first demonstrate flow-limiting disease, otherwise everything else is irrelevant. Revascularization is not an issue. What is complicating things now is, in my practice, I see a lot of patients who have FFR positive disease, but not angiographically significant disease. And remember, all the revascularization trials used angiography to get into this trial. And if you have a diffuse disease and the FFR is affected by that, like one of the patients Ron showed, the question of whether you want to revascularize them or if the grafts will remain alive if there's a significant amount of antegrade flow is a problem that is becoming very common. So this is an area of the FFR positive disease but not sufficient angiographic limitation is going to be a big challenge in future. Once you have decided he has flow-limiting disease, there are two branching points: demonstrate ischemic myocardium or demonstrate dead myocardium. The tests are completely different. For ischemic myocardium, the assumption being if it is ischemic, it probably has it's crying out for help and it has something alive, and Ron will show the biology of this at a later time. Nuclear imaging, which Ron will cover in a few minutes, and echo are the two options. If you want to demonstrate dead myocardium, cardiac MR is the option. People always confuse these two. They are not equivalent. One is showing what part is alive, one is showing what part is dead, and keep that in mind. Remember when I asked what does the group think has viability, a role currently? this is what the ACC/AHA guidelines say. Evidence of myocardial viability is also an important finding, and in some clinical situations may influence the decision making for vascularization. But it was not used to further expand the indications, which means that even experts on this panel really don't know or were not positive enough to go and recommend it in their algorithm. Okay, so here are two examples, and again I would like my esteemed colleagues to give me a sense of what they think. The echo on the left and the echo on the right, both are stress echoes. Which one is viable, which one is not, and what is the left panel showing and what is the right panel showing? Let's start with the left panel.
There are two different patients?
Yeah, there are two different patients, one on the left, one on the right.
Oh, I see. So you go vertically, all right.
Yeah. So let's talk about this, the rest, low dose, high dose, and post. What do you see?
And these aren't the same patient that you initially presented.
No, they are two different cases.
Okay.
Oh, I see.
So
well, there is viability.
Why do you say that?
Compared to the baseline and the LV apex and all that, I think it seems to contract.
So the low dose improves the LV apex, and then the high dose kills it.
Yes,
and then
so
recovers.
The biphasic response.
It's a biphasic effect, and Vera will tell you from the echo literature that is a very strong specificity for viable myocardium. So one of the messages from today's talk is biphasic effect is very important if you find it. You don't find it very often, but if you do, that's good. What about the one on the right? So the one on the right shows anterior wall ischemia. And the teaching point here is when you can demonstrate ischemia, it is assumed that that territory may be viable, right? Okay, so then this patient, when we had thinning, now how does thinning contribute to viability, whether we can benefit this patient after revascularization? In other words, is the anterior wall viable? And for this, the best test is cardiac MRI. And this is a very famous paper from Kim et al. It's about 3 decades old or 2 decades old, but the fellows should certainly look at this. This is a very valuable paper which started this concept. Remember, I told you this white part in a myocardium which is made black is dead scar tissue, and here it's subendocardial following a LAD territory distribution. What we looked at, two things were shown in this paper. One, the presence of late gadolinium enhancement is a high risk for bad things happening. But a more important point was the thickness of this white compared to the total myocardial thickness in that segment. You may not be able to see the pointer, but you can guess. If you look at the second row of the MRI images right side, you can see the apex is all white, suggesting that it is more than 80-90% of the anterior wall is dead. Whereas on the top, maybe only 50% or less is dead. So the cutoff has been once you get scar tissue, which is more than 50% of the thickness of that wall, that myocardium is not coming back. So that is the take-home message from MRI. How about thinning? So here is an example of SSFP images, which is like the echo images, chamber, 3-chamber, 2-chamber. You can see a big anterior wall motion defect with thinning, and what we saw on the echo kind of tells us that this is all scarred myocardium. But if you do the late gadolinium enhancement that we were talking about a little while in the bottom panel, you will see there is hardly any white in the area that is thin. And this goes against the echo literature where they said if the myocardium is thin, less than 3 millimeters or 4 millimeters, it won't recover. The echo literature is showing that this myocardium, which is extremely thin, if it did not have gadolinium, it will have functional recovery. Here is the echo before, the angiogram on the right, the LAD is gone. 6 months after revascularization in the bottom panel, the ventricle recovered, the wall thickness recovered, and they improved. So the teaching point here is thinning itself is not going to tell you whether it will recover or not. We should not rule out patients based on thinning. Thinning associated with dead myocardium, which is more than 50% of the wall thickness, is bad. Okay, here is another example. If you see on the top, that is the gadolinium panel. In the middle, the one which is moving are the angiographic panels, pre-revascularization and post-revascularization. Again, you can see pre-revascularization in the middle panel, extensive thinning of the anterior wall, but not that extensive GAD in the top uh, display. And you can see after revascularization, not only did the thickness come back, but the function also improved, not to normal, but a fair degree. Here is another patient without thinning, right? And so normally we would think hypokinesia, wall thickness is preserved, it's contracting suboptimally. This guy may improve. And here is the angiogram showing complete LAD occlusion. But look at the late gadolinium enhancement on the bottom. There is a dense infarct all in the apex. And no matter what we do, this guy is not going to improve. And so low likelihood of functional recovery. So to conclude, MRI shows you a bunch of things. It shows you thickness of the non-scar segment as shown in the arrow. It shows you the thickness of the scar segment, and the ratio of that is very important to determine viability. It shows you other things. And so the important message is echo and nuclear show you living myocardium that might come back. MRI shows you dead myocardium that will not come back. So keep this in mind as Ron goes into the finer details of viability. The last question I had asked was how many of us do viability. Here is the famous long-term follow-up study from Stitch. Whether you have viability or no viability, the EF doesn't improve and the outcomes don't improve, which creates a paradox. You need ischemic LV dysfunction and revascularizable CAD for viability testing, but a lot of this data comes from observational studies, and when it's studied in a robust manner, very often viability doesn't show any benefit. With that, I will unshare my slide, and Ron, you can take over and tell us about the nuclear part.
Right. So let's talk about the nuclear part. And I would tell you that Stitch is always a very complex study because, first of all, MRI and PET were not done in Stitch, and those are thought, at least by some folks, to be better ways to look at viability. The definition of how they define viability was very problematic in Stitch. And most patients actually did not go viability imaging. So if you actually look at the patients who underwent ischemia testing, also low. So many issues in that trial, which of course creates a lot of debates. But let's talk about viable myocardium. The basic definition, at least when I'm explaining this to our trainees, it's a myocardium that's still alive and has the potential to get better. There's different flavors, including stunned myocardium, which means the vessel might be open, but there's depression because of repetitive ischemia. So we see this sometimes after somebody has repetitive ischemia and ultimately the function goes down. And then there's hibernating myocardium, which is an adaptive regulation of the metabolism in response to chronic reduction in blood flow, repetitive stunning. So if you have ischemia, if you have, let's say, someone in the cath lab and you open up the vessel, it takes a while for the vessel, for the wall motion to recover that stunned myocardium, but chronically the myocardium becomes hibernating. Well, why is it that we even care about viability? Viability may tell us something about the benefit of revascularization. There's, of course, the other side of the equation is the risk. What is the risk of undergoing PCI or CABG? But we always have to match that against the benefit. And when we talk about benefit, that benefit is improvement in symptoms. In some studies, it's improvement in mortality or improvement in LV function. And I think it's important to keep all three of those endpoints in mind. The other point about viability, whether it's in that is really important, is that the cases referred for viability imaging are always the tough ones. So if there's a very easy case somebody has a cast, they have 3-vessel disease, they have normal EF, nobody will ever do viability in those cases. It's almost sometimes that nobody really wants to revascularize the patient. They have a lot of high-risk features. They say, okay, let's do a viability study. So it's important to know that these are always the challenging cases when we do viability. Another important point to know is how coronary disease progresses. So as coronary disease progresses, and we look at the myocardium, there's progressive degeneration of myocardial fibers and more accumulation of glycogen. And if I tell you that even though CAD progresses, the likelihood of improvement in function is much higher if you revascularize people that have earlier stages of degeneration and far less in advanced stages. Yet if we do viability testing, at least with nuclear, where we look at tracer retention will be demonstrated across all these stages because the myocardium is still alive in all these stages. So just because the myocardium is alive, it doesn't always mean it's going to get better. So how do we look at viability? And I know Dr. Chandrasekhar talked about this a little bit, but in nuclear imaging, we can look at the cell membrane integrity. So tracers like thallium and technetium are intracellular agents that have to go into the cells. We can look at metabolism using fluorodeoxyglucose to see if there's metabolic activity or glucose consumption. With echo, we just looked at, and also sometimes with MRI, if we do the right sequences, we look at contractile reserve. And of course, in MRI, we look at the infarct. So I think this point now is well made. So if we look at nuclears, when we look at technetium or thallium, which are the myocardial perfusion tracers, there are studies going back to this one from 1996 showing you that the more severe the defect by SPECT, the more likely the patient is to have scars. So when we see very severe defects with no tracer uptake, those usually mean that there's scar, but this is not perfect. And this is an example of a severe inferior defect by technetium imaging. And when we look at the MRI here, we see no late gadolinium enhancement, maybe just a tiny bit here, but for the most part, this is viable myocardium by MRI, despite the fact that there's a severe perfusion defect by perfusion imaging. And these examples certainly are ones to come across, which is why looking at rest perfusion alone and seeing a severe defect might not be enough to tell us, is this dead or is this viable? So what we actually do if we want to do nuclear imaging is we do metabolic imaging with fluorodeoxyglucose, which enters the cell just like glucose does, but because it has this 18 fluoride moiety attached to the glucose, it's something we can image with FDG imaging with a PET camera. So here's an example of how this looks. This is a 48-year-old male. He had an occluded LAD, and he was sent to us to evaluate is the myocardium viable or not. And when we do this, we do rest perfusion images, which you can see on the top rows, and on the bottom rows below each one is the FDG imaging to see what's metabolically active. And what you can see here is a large severe defect across the LAD. You can see the mid-anterior wall, the distal anterior wall has very little tracer uptake, so this would be a severe defect. It involves the entire apex. But when we look at FDG imaging, we now see increased FDG uptake involving the entire apex and the LAD. So this is an example of widely viable myocardium in the distribution of the entire LAD, telling us that this patient would certainly benefit from revascularization in the LAD. Now, of course, if we saw ischemia in that area as well, that would be another sign of viability. So ischemia, by definition, really implies viability. So when we look at PET imaging, we always do two sets of images, one to look at metabolism with FDG, one to look at perfusion. And when there is a reduction in perfusion but preserved FDG, as the example that I showed you, this is hibernating myocardium. When you have scar, there's an equal reduction in both perfusion and glucose uptake, so there's absence of both, and that is scar. And then there's often cases of what we call non-transmural scar, where there's a little bit of FDG uptake, corresponding to the reduction in perfusion, but it's not as intense as a full hibernating myocardium. Now, when you do perfusion imaging, this is a rest perfusion from a patient, and you can state, based on this alone, that there's no scar. So when the rest perfusion, and this is now not FPG, this is just perfusion using technetium. If you see a normal perfusion at rest, you know that there's no scar, but you don't know necessarily if the EF will recover. But if you do ischemia imaging and you see a large amount of ischemia, now you know that the anatomical lesions are ones that are causing ischemia, and this is someone that is much more likely to benefit from revascularization, which is why, and this point was made earlier, looking for ischemia is always helpful in these cases. And finally, for the last slide, I'll just share with you that even though on imaging we look for the amount of ischemia and the amount of scar and the amount of remodeling, there's many other factors that we need to consider when we want to determine if a patient will improve. Some of these we will know. We don't actually see the cellular architecture, but often we want to put this in context with the likelihood of achieving successful revascularization and, of course, the other comorbidities. And also the timing. So if patient has LV dysfunction for many years, it's much more likely to be scarred as opposed to someone who's presenting now, and these are relatively new symptoms and new findings. We'll stop right here for our discussion.
Thanks, Ron. The talk is open for discussions while our faculty is gearing up. Couple of questions from the audience. Nat, you might want to take this. Role of strain in viability and role of myocardial contrast agent, LV opacification, I guess that's what they are meaning.
All right. In terms of strain, there are some studies, but I don't think it's pretty well settled yet. And right. So I don't think that would be the first approach I would use to assess viability. Maybe an additional one, but I'm not sure about that. Contrast, two different things. One is LV opacification, so that we can see that cavity and the myocardium better, particularly when we do tests like low-dose dobutamine. And one can actually look at perfusion, but no agent is approved for that right now. You know, in the early years of contrast echo, we all did a lot of studies on perfusion imaging, but later on it has kind of gone out of the way. I hope it will come back again. It does work, and with vasodilators and then contrast imaging. So at the moment, that's the status as far as my thinking goes.
Thanks. Ron, how do you use viability in your practice? Do your colleagues ask for an echo? Do they ask for nuke? Do they ask for an MRI? What's their first test of choice? And then I'll come back to you on that.
Yeah, I think this is a common question, and we have a very large imaging program, and we actually do these imaging consultations. So this is one that they often tell us, we want to do viability, what should we do? And for us, the two most common imaging tests are MRI and PET, and people ask, well, which one should I do, an MRI or a PET? I think one of the technical issues in PET is that you have to make sure patients are fasting, and then we give them a bunch of sugar to induce insulin. Patient, I didn't go into these details, but and then we administer insulin. So either through endogenous insulin production by giving someone sugar or giving insulin, you're promoting increased glucose uptake by the myocardium. And that is something that is more difficult to do in patients with diabetes. So that's just a caveat for PET imaging. But in general, if I think most likely this is someone who's going to have viable myocardium, I think MRI, if we don't see any LGE, is actually really useful. So often, if I think likely there's not going to be a lot of scar or any scar, you know, maybe I have a hint from an echo that the EF is actually pretty good, there's nothing regional, I would say do an MRI. If there's no LGE, that gives me a lot of confidence that there's no scar, and then to proceed, obviously, given that the anatomy is conducive. The advantage of PET would be if we are also looking for what's called peri-infarct ischemia. So we know that there's some scar, and we want to know, is there ischemia? And in the presence of scar, PET is actually better suited to look for what we call peri-infarct ischemia, and if that's present, that would help you push towards viability. So PET would be particularly helpful there. And then sometimes there's very challenging situations because viability is not a black or white. When we show these cases, there's like there's the scar everywhere and everything is viable. But a lot of cases have a non-transmural scar where you do MRI and you see some LGE, but maybe it's only 25% in transmural extent, and you want another test to know what's going to happen. And I think maybe doing a dobutamine echo, maybe then doing the PET, but sometimes in the very difficult cases, we end up doing more than one test. And in fact, there's literature showing that that improves your specificity.
Thanks, Ron. Nat, how do your colleagues ask your help on this?
Well, depends on the hospital. Little more intellectual discussion at Tufts in a university setting, and at Hoag it's a big regional center, private practice groups. I don't think in a private practice setting they spend too much time thinking about viability. Should the coronaries looks bad, stent it. That's what is going on most of the world. And but in a academic center, it's a little different story.
Okay, so one of the interesting questions, either one of you can take it, and then I'll jump in. How early after a myocardial infarction can you or should you be checking for viability?
I think that's a great question because there's very important biases. I'm glad somebody asked that. So when we do PET imaging, looking at glucose uptake, there's inflammation in the myocardium early after an MI, so you are going to overestimate the amount that's alive. And when you do MRI, there's actually edema after an infarct, and that can cause more gadolinium uptake. And as a result of that, you'll see more gadolinium, and you're going to overestimate the amount of infarct. So these are biases in totally different directions. One, you're going to overestimate infarct. One is you're overestimating viability. And either way, I think after the acute period, if you have the luxury, either I would wait a couple weeks, or at least when you interpret this, you have to interpret this in the right context.
Right. So this question doesn't really come up in the peri-infarct period, right? So viability is looking at revascularization for improvement of EF and probably outcomes over a longer period of time. In the peri-infarct period, either you got a primary PCI or you did not. And if you did not get a primary PCI, it's rare that some surgeon would go in and operate for non-acute indications, right?
Well, we see a fair amount of people admitted to the hospital. Maybe it was an NSTEMI. You look at the coronaries, you see a lot of bad disease, and you say, okay, let's do viability.
This is STEMI.
What's that?
The question was STEMI.
Oh, no. Okay, yeah, I'm sorry. STEMI is a different ballgame, right?
Right.
I missed that
and
part.
And where it becomes important is there is spontaneous improvement over the next few weeks after an MI. And that's the reason we don't throw in an ICD 48 hours after the MI. And Nat, do you want to add anything? And then we'll go to the stitch trial for just a second.
No, I agree with you. STEMI is different. And then a post-infarct period later on, NSTEMI is different, and so it depends on the patient.
Okay. Look,
and hibernating, that's another story. Yeah.
There's a question from the audience. The stitch trial shows viability doesn't improve, but both of you emphasized the determination of viability. Why is there such a paradox? So let me take it first because Ron already started his talk with the fallacies of the stitch trial. So if you look at the viability, it's a very important idea. That 20 years ago, there were multiple papers, including one from Ron's current boss, Marcello Di Carli. And then there was a very famous meta-analysis called the Allman meta-analysis, which showed two things at that time. It showed that people with viability who are not treated have a bad outcome, and people without viability who get surgery have a bad outcome. So if you have viable myocardium and don't treat it, or you have non-viable myocardium and go and do bypass surgery, both of them do bad. And in the meta-analysis, it showed blowout values for revascularization when you have viability compared to non-viable. And I don't often remember the numbers, but there was a 70% round ballpark figure difference between the two groups. Subsequently, multiple studies have looked at this. Whenever it is done in a formal, systematic manner, whether from the oath or there was a British trial which stopped halfway through, one Canadian trial which was looking at PET, and the Stitch trial, both the initial report and Arshad Koyumi's recent paper, all of them uniformly have failed to show benefit. Now we can argue that they didn't use the state-of-the-art techniques, but it's like stenting and benefit in chronic angina. You can always say, but you didn't use DES, but you didn't use the latest DES, but you didn't use this. So it's like a moving target, but the general feeling is there may be benefit in some subsets, but at this stage we don't know. We know who doesn't benefit, but we have good evidence that this segment will improve our traditional testing, and more importantly, whether it's long-term outcomes. There was a Canadian PET trial, 6 centers, beautifully done. Even that was negative, but when you go and tease out one center, which was the most expert center of Rob Inland's group, they thought that in their patients, viability made a difference. But then you can change the rules. If you're talking about the whole study, then you can tease out something. So gradually, I have become less and less of a believer, and we only use it when we are taking patients with EF of 25, big baggy hearts. The surgeon is hesitating to go, and so we use viability at that time to say, yeah, perhaps it's not a good idea to go. So, and in our practice, CMR is the workhorse. Go ahead, Ron.